Hello everybody, my name is Dr. Yodpong Chantarasorn from Bangkok, Thailand. Today I'm going to present So I finished my fellowship training in Bangkok and then had an overseas study in Mass Eye and Ear with a certificate in applied biostatistics. So my work positions include the head of retinal unit in my university hospital and has been a board committee of Thai Retinal Society and Thai Cataract Society and also a representative of Asia Pacific region of the American Society of Retinal Specialists until present. So I'd like to present all the publications that I take part as an principal investigator, and this will be sorted by diseases. Let's start with the R. So first and foremost, we discovered the findings of intraretinal migration of silicone oil bubbles, as well as its risk factors and its surgical treatment in this case series. And later on, many surgeons also found the same findings. We also showed how to express the oil bubbles from the intraretinal tissues by peeling the membrane first and use DDMS to squeeze gently the oil bubbles from the pocket inside the retina. And interestingly, those patients who had refractory DME without any responses to anti-VEGF had complete resolution after the single surgery without additional pharmacologic treatment. We also published a paper about the association between VEGF SNPs and DR development in Thai patients with type 2 diabetes. And here's another paper showing that in real-world practice, most diabetic patients lack of awareness to have DR screening unless they have the DME development, they could be visually asymptomatic until early PDR. We found that two-thirds of patients took more than 2 months to have DR checked, although our hospital setting had one-stop service from medicine to eye department in the same day without additional cost. We also performed a study for those with end-stage DR where we implanted piggyback with central magnifier for improving reading in those with subfoveal exudates or scarring. And also patients with severe diabetic macular ischemia or those underwent TRD repair where the condition appears to be stable like this patient. Let's move on to the AMD part. We published the Tower study report number 2, mainly analyzing retinal fluid fluctuation during wet AMD management, represented by a new parameter called fluctuation index that corresponds better with not only the unstable patterns of CST, but also superior correlation with visual outcomes when comparing to the traditional standard deviation of CST. Like this patient who relatively had normal value of CST-SD but abnormally high fluctuation index which resulted in poor long-term visual outcomes, and that should urge us to find the real cause of insufficient treatment. We also report a temporal and dose-response association between regression of drusen and the use of PCSK9 inhibitor, the next generation of LDL lowering agent that binds to PCSK9 protein, thus improving LDL receptor function throughout the whole body, including RPE cells. And my team and I further identified a method that could produce PCSK9 inhibitor in a nanobody form that may be applied in a wider range of application. So in atrophic AMD, we found that patients who took dual antiplatelet shows lower GA expansion than those who did not. And this may support the theory that VEGF-driven MNV was the compensatory mechanism stimulated by choriocapillaris insufficiency and outer retinal hypoxia. Moving on to the next one, this prospective cohort aimed to find differences in baseline characteristics or risk factors, including OCT angio finding using Plex Elite between drusen-related NAMD versus pachychoroidal vasculopathy. Here's the study method. So we found that patients with PNV were younger than those with typical drusen, suggesting that apart from aging process, there may be additional factor affecting the MNV development, especially some risk factor of the pachychoroidopathy like chronic sleep deprivation and history of CSER that more prevalent in the PNV group. We also found that PNV had focal rather than widespread involvement of choriocapillaris insufficiency, which may explain its better outcomes compared to drusen-related MNV. And there are three patterns of MNV based on OCT angio findings. And the closed circuit or loop pattern of vessels showed the most persistency of retinal fluid after anti-VEGF treatment. We also published a case with essential thrombocytosis initially presenting with ophthalmic artery occlusion with many interesting signs, including aortic choroidal infarction that may be related to SPCA occlusion. Interestingly, the MRA showed complete occlusion of left ICA, and the ICGA showed focal choriocapillaris occlusion in the fellow better-seeing eye. For the study regarding CSER, we found that baseline urine cortisol levels showed positive correlation with foveal choroidal thickness in both eyes, and no such correlation was observed from either serum aldosterone or testosterone, so we selected low-dose cortisol antagonist or ketoconazole to treat CSER in a short period of time. And we found that the median time to complete SRF absorption was shorter in the treated eyes compared to the control. Regarding surgical part, we initially developed a technique for non-retinal specialists to do sclerofixation of foldable 3-piece IOL using double suture, and the common results showed that most of the parameters were comparable to intrascleral IOL fixation. And we further developed the technique for those who are not suitable for Yamani's technique, like patients with iris damage or poor AC view. And the technique is performed using a relay suture. And the discovery is a high frictional force between scleral tissue and 6-O-proline that could stabilize the IOL position even without the terminal bulbs or flanges. Because we found that a residual section of proline almost always occurs despite exaggerating the heating process, and when combining with the haptic pushback maneuver, this may increase the risk in the long run, including IOL instability or knob exposure. So instead of performing flanges and have a big bead underneath the conjunctiva, we perform relay suturing bypassing the curved needle through the pre-existing conch buttonhole, pre-existing needle sclerotomy, and partial thickness sclera parallel to the limbus for a length of around 4 mm. To remove the sutures, the eye was kept hypotony and the sutures were pulled firmly while using the small scissors to press against the sclera before cutting the outside suture, and this allows the suture to retract or retrace slightly into the sclera as the IOP normalizes. Scleral imbrication and retinal expansion for chronic large macular hole. And tealing technique for those with macular hole associated with MTM with or without schisis components. Recently, we published a paper about minimal gas vitrectomy for idiopathic medium-sized MAC hole. And the two main principles behind this technique is to decrease contact pressure on the fovea through the use of small volume of pure gas bubble, and secondly, to shorten the time the gas remains in contact with fovea, whereby the patients could stop prone positioning once the inner hole was sealed. So after completion of ILM peeling, instead of performing traditional FGX, the eye was kept hypotony before injecting around 0.8 to 1 ml of pure SF6 with a concurrent BSS tapping using 25 gauge needle through the infusion cannula. So we found that patients undergoing MGV showed less proportion of disrupted EC layers, thicker foveal thickness, and a trend toward better BCVA at all time points. Regarding studies involving RRD, we found the factors associated with persistent fluid after vitrectomy for RD repair, and these include choroidal thickness of more than 280 and RPE changes in the fellow eye. So thank you so much for your kind attention, and I hope to see you all in Manila. Bye.